Thank you everyone for coming to TCT, and this afternoon we are planning to show a case of TAVR with a Medtronic core valve, and we are very thankful to our friend and colleague Dr. Kodali, who is always a source of encouragement, and that's how we started the valve program in Apollo Hyderabad. We've been doing these cases every month, about 25 plus we did, and we are very thankful to you, Sushil. And this afternoon again, what we plan to show is a 80-year-old female. Before we go on to the case details, this is my colleague Dr. Gokul Reddy. Sushil is there. Dr. Sudhakar, our cath lab sister Jamna, technician Reddy, Narsimha, and others. And then we also have Subhash and Sanjeev with us. And we thank Apollo management and the entire team for the cooperation, other senior cardiologists, Rath, Manoj, Badrinath, and entire KMK and entire other team members for all the help. Without much this thing, I request Sudhakar to present this case.
Respected chairpersons, senior colleagues and my dear friends, a very good afternoon and warm welcome from Apollo Hospital, Jubilees. Here we are in live with TAVI live case. Here is a 80-year lady, thin built, weighing of 35 kg, presented with dyspnea and exertion for the past 3 months and orthopnea 3 months back. Since then she was on treatment with no comorbidities. Next. On evaluation, she is found to be having severe aortic calcific stenosis. ECG showed normal axis with concentric LVH. Next. 2D echo, parashon long axis showing densely calcified aortic wall with restricted mobility. Next. With mild to moderate MR. Next. With peak velocity of 4.9 and gradients of 96 and 56. Next. With coronary angiogram was normal, right system is normal, left system is normal.
Move on.
Okay, move on. Okay.
Move
Next.
on.
And this is the CT aortograms.
So I guess the key parts of TAVI is understanding the anatomy and understanding the risk. This is the CT scan. We're measuring at different levels. The first thing that you see is that you'll see in the next slide that it is a type 1 bicuspid valve with fusion of the left and right cusps. The annular area, if you measure at the annulus, is perimeter is around 85. And so, by normal standards, that would be a 34 millimeter core valve. But it is a type 1 bicuspid with a calcified raphe. If we go to the next slide, you can see that the ascending aorta you see is a little bit dilated for a woman her size, but measures about 35 to 38. On these slides here, again, you see very clearly the fusion, calcified raphe between the left and right. That distance between the commissures, between the non, which is not fused, is about 26 to 27. So one of the discussions that we wanted to have is how do you size the valves? We see a lot more in Asia, both China and India, of higher incidence of bicuspids. A lot of the cases we're doing here are bicuspids. Majority of them are type 1 bicuspids with fusion and a calcified raphe, and that obviously changes things. Next slide. The angle of the aorta, it doesn't look very horizontal, it's around 50. And you see the aorta again, very mildly dilated, but not terrible. But the ascending aorta is fairly clean. Next slide. Vascular access is good. She's, again, as mentioned earlier, very thin woman, 35 kilos. But vessel size is around 6, down at the femoral, 6.5, and up in the common iliacs about 8. So I think that's the last slide. So perhaps a little discussion from the panel, and then we can discuss what we've done so far and where we're at. What are your guys' thoughts about the case? The surgeon had to step out for a second, but mainly because of frailty. She doesn't have a lot of comorbidities. Her creatinine's a little bit higher. GFR is down. Creatinine's 1.2 for someone that's 35 kilos. But it's really from the frailty aspect that was felt to be very high risk for surgery as well.
Sushil, this is Vijay Iyer. So could you talk me through your plan? Are you thinking going with a smaller valve compared to what the perimeter measurements would lead you to normally because of the bicuspid valve?
Yes, exactly. I mean, I think in general, the question in all of these things that you have to ask yourself is it truly bicuspid, or do you think the raphe is going to open? If the raphe opens, then obviously the sizing is different, like a tricuspid. But when you have a bicuspid, a lot of the sealing occurs at the leaflet tip level, and so you don't need to really, you're not sealing at the annulus. You're going to seal at the leaflet tip. So some people have talked about supraannular sizing in these patients, measuring that distance above. whatever you do, you're really trying to understand where is the valve going to seal. And I think that's one of the more important questions. And here, we believe that it's going to seal at the leaflet tips. The raphe is calcified. And so for that reason, our thought is to, these are sometimes difficult to open. So we're going to, our plan was to pre-dilate with a 22 millimeter balloon and then go with a 29 millimeter core valve. Do you guys have any different thoughts? Or?
I think that's a good plan, Sushil. I mean, as you point out, these raphe, when they're calcified, are like pieces of bone. They don't really, dilate well. And I think the idea of putting in a 34 doesn't seem.
Yeah, she's very
like the right thing.
frail and thin lady. And another important aspect, so we proceed with the case because patient is pressure is dropping a little.
But before we do the balloon, we should try and get some pressures. Her systolic is about 90/50. If we can give a little bit more support, get her blood pressure, before we dilate about 120.
Sushil, I wonder if your wire is kind of laying on,
pinning
because the diastolic's pretty low. I wonder if centralizing a little bit.
We didn't. The echo image didn't. She has really mixed valve disease, and that was one of the debates about ballooning or not. She has at least mild to moderate AR, maybe a little more, on the echo. The echoes didn't play. Can we go forward and do the shots that we've done? Can you go forward?
So see how the diastolics come up now.
Go forward.
We'll
Go
briefly
forward.
run through the steps also.
So we crossed over just to do a quick picture. Access looks good. Go next slide. You get a shot. Then next slide. This is our aortogram. You'll see there's a fair amount of AR at baseline.
Yeah.
But I think despite that, we feel that we have to balloon this because the wire. We didn't save the wire crossing. But pressure's okay now. Good.
It was hard to cross.
It was hard to cross. It was very eccentric. So in those scenarios, especially it looks a little bit more horizontal in this aortogram. And so we'd be worried about the way the core valve would deploy. And for that reason, we pre-dilate. And the question is, how aggressively do we pre-dilate? Our thought was a 22 here.
Is the valve prepared?
The valve's prepared. Next slide, we'll show you. So this is how it crossed. You see that?
Yeah. It's always scary.
Yeah. Next slide. So we put a stiff wire. We exchanged, next slide, for a pigtail, which went to the apex. Then we put our confido wire in. Next.
So
here's
Sushil,
the valve is prepared. We checked on fluoro that there were no issues with no issues with the back one. Yeah.
So this is a 29 Evolute or is it an Evolute Pro?
Evolute.
The LV function is normal, Sreenivas?
Yes, LV is normal. She has mild to moderate MR, but could be secondary to this. So what we thought now is we've taken a balloon to predilate, and then we have put a stiffer wire. Now I'm going with this balloon for the dilatation.
And you have to be careful in these bicuspids, and you have to be ready to go quickly because once you balloon, sometimes you get a lot more AR. She's got a fair amount, so she may tolerate it okay. You can hold this out.
Sushil, do you have the practice of injecting during the balloon inflation? Or?
I generally don't. Her creatinine's a little bit, GFR is down a bit. I don't think we can definitely do that. Here we go. Let's get the wire.
So how big are her sinuses, Sushil? Because if they're big enough, I wouldn't bother with the injection. And if her coronaries
sinuses are very big.
Yeah, if this coronaries are high enough, I wouldn't bother. I'd just get to business. Because she seems like she's a little tenuous.
Okay.
Yeah. Good. Okay, that's good.
Okay.
Okay, we ready? Okay, pacer on.
Inflate.
Yes. Pacer off. Floor. So the syringe came off. Hang on a second. Let's get negative on here. Her pressure's okay. She has some ectopy, but pressure's okay. So what do you guys think of that balloon? The balloon opened.
Yeah, I'm not quite sure you profiled the balloon even to its nominal size. But it looks like you got a little bit of an opening.
That's the problem.
I think it's enough, Sushil.
Yeah, the idea of the balloon dilatation, I think, is to get the valve in. I think that should be enough to get the valve in.
There is one thing, though, with the Evolute valve is that...
So pressure's good, so we have a moment to talk, so please go ahead. Yeah.
So there is one thing with the Evolute valve. If you're dealing with these kind of bicuspid valves that are kind of calcified, sometimes when you first deploy, if it's constrained, it doesn't have the radial force as like the core valve classic. And once you start to deploy, and if it's in that constrained view, it has more of a chance of popping out after you let it go. And so I think it was a smart choice to pre-dilate And
Next.
usually we don't have
Next.
to pre-dilate to get good
Balloon.
expansion,
Oh.
but in this case I would.
No, back one. Back one more. Back one more.
Didn't store that? I did cine also.
Okay, this
Yeah,
is it. This is it.
one.
So here we see the balloon inflation. So there's still a waste, right? We came off cine a little bit quickly, but you see the waste there, right? On the non-coronary side,
Yeah.
that chunk of calcium.
I think it's enough.
But I think that's
Yep.
probably
Okay.
enough to get you a good deployment.
Yeah.
Can you hold negative?
Mr.
I'll back
Shield,
up.
we were talking about how sometimes when you go to like 80% with the Evolut and it looks like it's still not opening, you should just take the thing out
Re-
and dilate more because it has a high chance
on.
of popping out.
You have this?
So the other downside of dilating it aggressively is breaking the raphe, and if you want to put a smaller valve with 29, do you think that is maybe an issue?
I think those raphes are fused. And it's so calcified. You ready for pressure?
Yeah, yeah.
Okay.
I mean, it's a $32,000 mistake. If you start to deploy, you look with the echo, and there's a lot of AI because you crack the raphe.
Okay.
But indeed, you
Valve,
do
come
have a
over here,
chance
please.
of taking it back out and putting a bigger one in. But you know, these ones that
Good
are
control.
calcified like this, the raphe doesn't usually open. It's like you know, the surgeons when they describe this, they say it's like like a bone.
Spicules of bone.
Yeah.
What is the real incidence of AI? Because we would aggressively dilate, and most often there is no significant AI at all
Yeah, it's
clinically.
very rarely that you get into a circumstance of
Laura?
hemodynamic compromise just
going
because of a
easy?
BAV.
So we're going
I
into
mean,
the
I
valve.
run across the
Going easy?
street here, the very crowded streets, and most of the time I don't get run over. You know?
Ma koncham opkavatama. Now we are going inside.
Okay, so we're going ahead with the valve here. So stop for a second. So there's been a lot of discussion in the U.S. and a lot of these valve meetings about trying to orient and keeping the commissure away. We haven't focused on that here because these coronaries aren't high. But in general, for most patients, if you keep the side port, like 2 o'clock, the orientation will be nice that you're not in front of the left main. Can we pan up a little bit so we can see the aorta?
I think you never notice the shield, especially with bicuspid valve.
Yeah, I agree. That's why I didn't bother because the coronaries were so high, sinuses were big. So I'm just holding a little rail. Keep going, please. Don't stop.
So one thing that's being talked about a lot, Sushil, with these self-expanding
Stop
valve is, what's the best view to deploy in, and is it the coplanar view? Do you have to come caudal? Should you do it in RAO? Should you do it in LAO? The
So-
036
Stop there.
business.
Okay, so, well, here we got a little bit lucky in that our coplanar view, we don't have a lot of parallax, right? I would say I would probably take this view. What pressures? Wait, what's our pressure?
Can you show us the
Pressure is
screen?
on.
We are actually
Okay,
seeing only
we're
the
gonna have
handles.
to go to floor up.
No, no, pressure you stop totally, madam. Increase the
No,
anatomy.
we're stenting open a leaflet.
Okay.
So you need to give some support for blood pressure.
Yeah.
So you know, pull up a little bit. Okay. Okay, open to pressure. Can we see pressure? No,
Pressure is down.
Looks like
charge,
VT.
charge, please.
Is she pacing? No.
Face the.
Floral for a second, please. Okay, we're back. Okay, we're back.
Okay.
Okay, so let's stop for a second. Let's let her recover. So what you saw there was when we crossed, we basically, I think we stented open that leaflet. She had no blood pressure because we had wide open AR. So one of the advantages of a core valve or Evolut is at that point, don't worry about the position. Get to 80%, which is where we are now. We can recapture if we need to do anything. Okay, keep her hand down, please. She's okay. And you can recapture and reposition later if you need be. But if you get to this point now, we've stabilized the patient. We have a functioning valve, and her blood pressure recovered. If you wait at that point and try and see what's going on, she'll arrest, and then it's too late. So that's why as soon as you cross, your eyes have to go to the blood pressure. The blood pressure, I don't know if you guys saw the blood pressure, but
Yes, we did
it
see.
was essentially flat. So what we did at that point was quickly just deployed to 80%, and now you see the blood pressure's back, but now it's a mactopy, but the blood pressure recovered.
Yeah, you saw her diastolic pressure was like 10.
Huh?
So.
Pressure is down again.
No, it's a lot of ectopy now, unfortunately. I think that's the blood pressure now. Can we just look on echo, please? Unfortunately, we don't have the echo slave, but I don't know if the camera can turn, but let's see, make sure there are no issues.
It looks like you're pretty good depth, Sushil. I think you're you know, kind of 6, 8 maybe on the other side.
So from an anesthesia perspective, we'll need some more help with the blood pressure.
I might pull the wire back a little tiny bit too,
Okay.
Sushil, and see if.
Okay, that's good. No effusion. How's the LV function? That was a good idea, Dwayne. See, a little less ectopy and the blood pressure came back up. Okay. So unfortunately, again, we don't have it slaved, but you'll see that if you could see the echo, the LV function's good. There's no effusion. Whenever pressure's low, you're running through the complications. What could it be? We could have a pacemaker perf. We could have an LV perf. Theoretically, we could be including the coronary, but not at this stage and not in this patient. We could have just become ischemic and had a dead LV. So right now we ran through, everything's okay. So I think what we'll do, we have a touch of parallax. If we can stay on fluoro, and can we stay on fluoro? Can we move slightly cranial, please? A little more. Is it going the wrong way? Or that's the wrong way. Go caudal, please.
Maybe a little more L actually.
Can we go more L?
Sure.
LAO, slightly LAO. I have a light in my eye, so I can't really see well. Somebody can move that. That's a little bit more. Good, that's good. So let's take a picture here. 10 for 15, please. 10 for 15, can you make it 15, please? Can you make the injector 15, please? Good. Can we mag up one?
It's looking good, Sushil. Looks like actually really only like 3 or 4.
Yeah, so I think we might just, again, given how sick she gets.
It's going to lay over onto the non-coronary
Yeah.
side, so you're going to end up,
Okay,
you know.
let's do an injection here.
Okay, ready for it?
Inject.
Yeah.
So, you know, we might have to post-dilate, but the position is good. So we're going to accept this. And also, after we deploy, some of that may open up. But I think from position-wise, what we're trying to look at, we're okay here. So I'm going to deploy, if you guys agree.
I deploy with a little forward tension too.
So Sushil, can you
Slide
push it
Yeah.
forward
Yes,
to
I
the
think
outer
it's,
curvature will help to align the valve better?
Yeah, I pushed it.
Yeah, that's in a little bit. Okay, I'm going to deploy there.
We
I
can
think also as Dwayne pointed out, the valve will cant itself to the greater curvature once it's deployed, so giving a little bit possibly height on the left
Just pull
side.
your
so-
wire in too.
Yep.
Yeah. So after we deploy, the key things now, I got to make sure I don't pull out the valve. And again, we're low enough, it won't, but I pull back the wire. We'll need that 14 French sheath back.
So see that kind of constrained appearance
Right up,
there?
just
Yeah.
above the annulus, yes, you
Yeah,
can see it.
yeah. And that, you know, you'll see that with bicuspid valves. And let's see what the gradient is.
So the question is, from an AI perspective, do we need to, so we recapture the nose cone. Do we need to balloon this, right?
It didn't look like the valve flowered any much more at
We can
below
do
the
one more
annulus,
shot and
so-
then decide.
Yeah.
So we have a 14 French ready, okay. So we're just going to take this out.
Yeah.
I think you're fine. Take your time.
Yeah. So
Check
now
some
blood
gradients and
pressures
stuff.
are good. We can check gradient. We might need a pigtail back.
I usually give a little hand injection through the pigtail that's
Lower.
in the frame just to get a sense of the depth.
Not much of
Before I pull it
indentation
out.
also, no?
So your hemodynamics are, again, a little compromised.
Yeah.
Ectopics, frequent ectopics
Ectopics
causing
are-
the pressure drop.
Okay.
Yeah.
Let's get a pigtail first. Get another pigtail. Hold the sheath and take the dilator out.
It looks,
So you see again, as soon as the ectopics go away, her pressure recovers.
Yeah, you know, the wire is tenting a leaflet up, I think.
Yeah. Okay.
I think you're going to be fine in
Can
a
we
second.
flush the sheath there? Flush for the sheath, please. That's contents here. So as you can see, things can go south very quickly in these type of cases. And so, again,
So you got a diastolic of 75. I think you're going to be good.
yeah, I think, and again, I think that's one of the advantages of a self-expanding in this scenario is you quickly get to 80% and you can reassess. Then you can breathe, because you stop breathing when you see the pressure, and you can breathe and the patient can breathe, and then you decide what you want to do. Okay, well, I'm going to take this wire out. So let's keep the pigtail in. Good. Okay, good. So we'll just check our gradients here. And then we'll do one shot here again. Because again, with self-expanding, give it time to expand. And
pressure is
sometimes
huge.
it might
Right.
Looks
flare out
good,
a little
man.
more.
No
Yeah,
really.
well,
Well, can we get both on 200 scale,
200
please?
scale.
Both on 200. the flush, please.
Well, it looks very,
Look at that
it looks really good with
separation,
the good
yeah.
separation of the diastolic. I think
Yeah,
looks
I
really
might
good.
call this a victory and say we got lucky and stop.
You didn't get lucky. You did a good job.
Fantastic.
We'll take one. Reddy.
You want to do one more injection here?
Just
Yeah.
final shot.
Yeah, final shot, 10 for 15.
You know
please.
what? Why don't you take the one out from behind the frame, and then
Okay,
you
let's
can-
get a let's get a J
This one,
wire.
this pigtail. This
and then
pigtail.
and then you can
Come back
line
to
up the
this.
parallax from the
Yeah,
top. I
from the
find
top.
it easier
I
that
usually
way.
do the same thing.
Yeah.
That sheath is in still? Yeah.
Yeah, shit is fully.
We're having a little issue. She has no tissue. All the sheets keep sliding out.
Mm.
There's no soft tissue at all. So, okay, pigtail, push it back down, please. This one. Okay, good.
She's a little dry too, huh?
Okay.
30.
Yeah, we can give a little volume. That's a
Okay.
good point.
80 years
the
and
the
35
diastolic
years.
is low, so we can give a little bit of saline. If we can give some saline.
How's the echo with the?
The echo, the LV function was good. We don't have, they didn't have, can you see the AR? Do you have good, hang on one second, let's do one shot, then we'll let you look, okay? One second.
Sushil, we have to break away to Jaipur in about a minute's time. So
Okay,
if you guys
just
want to give
check
us a
this
Maybe
final
we'll
shot.
give you one injection.
One
then we'll see.
injection, then you can go there.
Let's
Right?
give a
one
little more
second.
L. And
Okay. We can always come back later and show you some final images if need be, okay?
Okay.
15 for 20, yeah, maybe do a little more, okay, yeah, just because. Huh? Indeed?
This pigtail.
I'll just leave it for now, it's not causing anything.
Okay.
Okay, that's all right, one quick shot and we'll let you guys go. Okay? All
Okay.
right, go ahead and Sine. So there is some there, right?
We'll probably post edit.
So I would probably post-dilate
Yes.
this. So, we have time, we're stable, post-dilatation is generally pretty safe here. We're not going to go crazy because the hemodynamics are okay, but I think it's worth one post-dil. But
just check with echo. Just make sure it's not the
The-
not the catheter
Okay.
still in.
Catheter problem.
yeah. So if you guys have to, I know you have to go. So
So
why-
we'll break to Jaipur, but we'll have an opportunity to come back to you guys
Just
maybe
check-
later to see a final picture if you decide to post still.
Okay.
AI is also
And then,
parallel.
fix the parallax and take the central catheter out and check whether it really is that much AI because the hemos look really good.
Yeah, I
man.
know. That's what I'm saying. Yeah. So we might investigate a little bit more before we decide to
Yeah.
do it.
Yeah.
Okay.
The other thing is the patient has already AR, so he will be tolerating it better.
Yeah.
And clearly her hemodynamics look pretty good.
Echo also shows
Let's see.
not much of
Unfortunately,
a
again,
vegetation.
you're gonna have to take
You
our
can't see
word
that.
because we're not slaved. Can we put some color there?
We can see the echo.
You
can
can?
see
Okay.
the echo. Yep.
Oh, you can. It is slaved. So let's see the AI, and then we'll need a short axis.
Actually, it is not much of a aortic vegetation on echo.
Yeah,
So
take-
we're going to cut to
Okay,
Jaipur
okay,
right now
absolutely,
and we'll
understand.
come back to you
Yeah.
Yeah,
guys.
yeah. Okay.
Thanks again.
Thank you.
good job, guys.
Right, thank you.
Well
Good
done.
case.
We took a picture after removing the pigtail as you suggested. Are you able to hear us?
Yeah, we can. Please go
Yeah.
ahead.
And then we thought it is slightly on decreasing. This is the other picture after compared to the one it thought it was less. And pressures were good and hemodynamically stable. We checked on the echo also. There's not much of aortic vegetation. So that's where we thought we would leave it rather than distorting and increasing, producing trouble. She had more AR before, it's less. I thought gradually expanding it will be heal up further. And,
Fantastic. I think the perfect is enemy of good.
yeah.
I think we
Then
should stop.
we immediately did a closure. Now this is the groin which is focusing. Obviously, unfortunately, can't focus on us anyway. This is removed, and the pigtail also we removed. She's maintaining narrow QRS. We just for the sake of checking again the end for completion, we did check next shot on the groin through crossover to the DSA picture. There looks like slightly indentation there, but flow is good and pulse is very well felt. So we left it without. We could have dilated with a small balloon, but I thought the good distal flow is good and there's not much of it. I think we left it that, and the patient is doing fine. Thank you, one and all.
Yeah,
Again,
I just have a question. Sushil
Next.
is there? Is
Sushil. Sushil's mic is removed, but
Okay. The question is, you were deploying the valve, and there was a patient who had a VT, and when at that 80% deployment, there was a VT, and finally it reverted to sinus, and then you had time to deploy it. What if the VT had continued? Would you have deployed the valve?
No,
Or,
Sushil felt it was more because of the valve being stuck in the open position with a free air rather than more of a VT per se. Before, again, she had it later. So problem which was happened was because valve was totally obstructing the aortic regurgitation, producing severe AR.
So
That was
the
the
things to
culprit.
think about when someone
Yeah.
goes into VT during deployment
Yeah.
are, is it the wire that generated the VT, or at 80%, are you occluding the coronaries somehow?
How cut karo?
So I take a quick picture to make sure the coronaries are open, because if the valve is obstructing, you knew, for example, in advanced planning that the sinuses were small or the coronary was low or something like that. I would want to know that
Ma.
before
Check
deploying the
pike
valve.
te vadu. Ayipindi.
Because if the coronary is occluded and the person is in VT because you've occluded a coronary, then you retrieve the valve and pull it back out. So it kind of depends in this case.
So you take an injection and then take a decision
yeah.
quickly with a VT.
Yeah. I can do it with the hand injection. So also the other thing that I do
Stop
is
karo.
I have a 20 cc syringe filled with
Stop
contrast
karo.
hooked up to the three-way stopcock, and so that I can give puffs while deployment is happening, so I know where the valve is, and then if something like this happens, I can give a quick injection and see that the coronaries are filling or that they're not filling. If they're not filling, then we retrieve the valve and take it out. But if it was probably actually the wire and the fact that the person had wide open AI and became ischemic.
So Sreenivas, it's a great case, and I think we showed a case. We had a hemodynamic compromise during the deployment, and very well deployed, well done.
Thank you. Thank you all.
Yeah.
Great.
Bye.
yeah.
Thank you.
Can we look at the next case?